Okay, all right, we'll get started. Thank you for everyone for coming. I know it's always much easier to listen online, so thank you for those who are here. So today I'm going to do mainly ID. I wanted to start with a little bit of derm, but the focus today is going to be infectious disease. So for dermatology, the main things you have to know this year in 3B is the dermatology language. So maybe practice with your friends how to actually describe lesions would be really important with all the language. The other thing is really skin cancer. Basic dermatology and histology, and skin cancer is probably the only thing I think that would be accessible in 3B. So I'm not going to go through all of this, but it's just, you'll have the notes there for you, and it's very self-explanatory, but this is just kind of like a glossary of all the dermatological terms. Most of them have 1 centimetre as a cut-off point. Sometimes like a vesicle, some of the textbooks, depending on where you look, say, you know, it's a clear fluid-filled lesion less than 0.5 centimetres, and others say less than 1 centimetre, greater would be a bulla. So it can change a little bit, but generally use 1 centimetre as the mark. And this is a second list of more specific terms that are really useful, and some on the right are actual more histology terms, which I'm not going to go through because you can read it all there, but yeah. So what I will go through is some benign pigmented lesions and skin cancer. So that's a picture from Underwood's, one of the pathology textbooks. So normally you have about 1 melanocyte in your stratum germinativum, the bottom layer of the epidermis, per 6 other normal basal keratinocytes. When you get a freckle, it's because you get increased melanin pigment, but no increased number of melanocytes. If you actually get an increased number, that becomes a lentigo. And that bottom picture is actually lentigo maligna, which is like a melanoma, malignant melanoma in situ. And what can happen as well in a lot of lesions, nevus is also called a mole, is you can get nests of melanocytes that they lose their dendrites and they become larger with more cytoplasm and more kind of granules, and they clump together in these nests, and they're then called nevus cells. They're still melanocytes. And when those nest cells are at the dermo-epidermal junction, it's called a junctional nevus, and that's often quite flat and pigmented. When the nevus cells extend down more deeply into the dermis, as well as being at the intradermal, the dermo-epidermal junction, they're called a compound nevus, so it's both. And it becomes more raised because whenever you've got like a dermal component, it's associated with more of a raised lesion, and it's still pigmented. And then sometimes you can lose the nest cells at the dermo-epidermal junction and just have them in the dermis, and that's when it's still raised because you've got a dermal component, but you can think of it as the pigment, those nest cells are deeper, so you don't see the pigment, so it becomes more skin coloured. You can also have like a blue nevus, which can kind of sometimes look like people worry about melanoma and nodular melanoma and things. One of the biggest other things is a seborrheic keratosis. They're really, really common, especially in elderly patients, and they can look quite ugly and nasty, so sometimes people can confuse them for melanoma. The buzzword for them is they've got a stuck-on or wart-like appearance. So they're often like a plaque or a nodule that looks waxy. It's usually quite well demarcated and symmetrical, which is a good feature, but they can be quite raised. They can have kind of like almost a bubbled or warty appearance on the surface. They look really quite like ugly. And they represent just a benign proliferation of epidermal keratinocytes. So they may be also called a basal cell papilloma. So now onto skin cancer. So basal cell carcinoma is the most common. It's 3 times as common as SCC. Again, it's usually in elderly patients, so it'd be very unlikely to get a younger patient. They're thought to arise from pluripotent stem cells within that basal layer of the epidermis, the stratum germinativum, from chronic sun exposure. There's a strong link to total sun exposure. The good thing about them is they very rarely metastasize. You get extensive local invasion, which gives it its name rodent ulcer, because it can really erode the surrounding tissue. But because it never really actually metastasizes, some people consider it probably should be called a basal cell epithelioma rather than carcinoma, because it very rarely metastasizes. It's not really a feature of a cancer would be that it would have to go through the basement membrane. BCCs are most commonly on the head and neck in 70%, and their appearance is typically a pearly or skin-coloured raised nodule. Like you can see some pictures up there, often shiny with surface blood vessels called telangiectasia, and rolled borders. So the borders the edges are kind of up higher and it kind of is continuous as surrounding skin. They may ulcerate, which may make them look a little bit like, for me, SCC, like that one on the right down, the third one there. They're usually of the nodular type. The histology, this is taken from the histology slides, I presume they're the same your year, but they form clumps of cells that are basophilic, which means they stain with basic stain. They're basaloid, so they look like the basal keratinocytes, and the cells all line up with the nuclei lining up almost like a picket fence, and this is called palisading, so that's a feature on histology. The treatment for BCC varies a lot. So if you're in like a GP setting, you can just use cryotherapy or like liquid nitrogen just to freeze it off. You can do surgery, you can use topical chemotherapy, curettage. Because it doesn't metastasize, we're not as worried about getting it all. So that's why you can use so many different things. And that will depend on the location, the type and number of lesions, and the patient preference. SCC is the second most common. And that's a malignancy of the squamous keratinocytes, so higher up in the epidermis. When SCC is in situ, it's called Bowen's disease, i.e. it hasn't actually spread through the basement membrane. These do metastasize, even though they do infrequently, but they can, so about 2%, with 15% from the lip or ear, which are high-risk sites. So they're, again, so strongly associated with total lifetime UV exposure, but also immunosuppression. So an exam question might talk about a transplant patient on immunosuppressive drugs, or someone receiving chemotherapy or with leukemia or something like that. And they're at much higher risks of getting SCCs. Again, they're often on the face, but also on the hands. So when you look at the appearance, they're often quite asymmetrical. They're indurated, which means they're firm on palpation when you actually touch them. Usually a plaque or a nodule, so it's like raised. And they're erythematous as well as variegated, which means they've got different colours. And they often have a surface that's keratotic, so extra layers of keratin and cells, or crusted, which is like whether it's dried serum or blood. So you can often see that, especially in the centre of the lesion, that often it's like quite white looking. And the other buzzword for this is heaped up edges, best shown by that at the top right, that picture there. And they can also bleed and itch. Histology shows irregular nests of these atypical squamous keratinocytes in the dermis, and they form like what's called keratinous pearls or pools. The treatment that's best is to actually obviously surgically remove them with about a 4 millimeter macroscopic margin and 1 millimeter microscopic. Sometimes they use follow-up radiotherapy. The main thing here is not to use like cryotherapy or topical chemotherapy because they can metastasize and you want to make sure you get it all. So you can't just like freeze it off. So malignant melanoma, so this is the least common of the three skin cancers, but it's obviously the one we worry about the most. So it's malignancy of those actual melanocytes, those pigmented cells produce melanin. It's rising. So they start in the epidermis and they extend both vertically towards the surface of the skin and down through the dermis, and that's called pagetoid growth. You get a similar growth in pagetoid disease of the nipple, which is with the crusting, which is why I think it comes from that. But of course, there's the most common superficial spreading melanoma that usually, at least initially, spreads radially, so kind of from side to side rather than down, which is good. So we don't want it to spread down through the dermis and closer to metastasis. So the risk factors, again, are very similar to what you would expect. I guess the thing here is, even though they are associated with UV exposure, they're much less associated than non-melanoma skin cancer. And young patients can get them as well. So because they're so severe, young patients potentially can lose many years off their life if they get melanoma. And they don't generally get BCC or SCC, but they can get melanoma. The ABCDE mnemonic is used to assess the actual lesion. So it's more likely to be a melanoma if it's asymmetrical, if the borders are regular, if there's colour variation, if the diameter is greater than 6 millimeter, or it's enlarging. And always ask the patient if the lesion's changed, and if it is enlarging, always take it seriously. The thing that's not as helpful is a nodular melanoma. So that second one from the left there. you can see that doesn't really apply very well to ABCD. It looks quite symmetrical and the border's regular and it pretty much looks the one colour. You can see the surrounding erythema. So they have the EFG for those types. So you look at the elevation, the firmness to palpation, and also how quickly it's growing. So if it's growing at greater than about 2 to 4 week periods, when you notice change within that time, you have to be really worried. Superficial spreading melanoma is the most common. It's about 70%, and it's not as severe, but obviously it will spread radially, but eventually it will still can get through the basement membrane and then eventually metastasize. So we're still worried about it, obviously. Nodular melanoma is about 15%, and that's particularly bad because it has growth upwards. You can see it obviously forms a nodule going up, but it's also going down right through the basement membrane and down through the dermis, which is bad. There's also the other types there. The other worrying thing about melanoma is about almost 20% cannot have any pigment in them, which makes diagnosis very difficult. I wouldn't want to be on the end of a lesion without any pigment and you'd be like, oh, it doesn't look like a melanoma, and then it is. And they can occur in other areas with like a pigmented epithelium, such as the eye, the choroid. In terms of spread and treatment, we can classify them based on two things: Breslow thickness and Clark's level. So Breslow thickness is a measure of the distance from the granular cell layer. So that's the stratum granulosum of epidermis. So it goes stratum corneum, stratum lucidum, stratum granulosum, stratum spongiosum, and then stratum germinativum. So it's like the third one, and that's often you can easily see like a line on the histological specimen, whereas the stratum corneum is like kind of all over the place and varying thickness. So you measure from that down to the deepest malignant cell, and they use that to kind of stage it based on T1 to T4, and the Breslow thickness corresponds with the prognosis. So you can see the 5-year survivals there. Obviously getting worse and worse the further the cancer is getting down. Clark's level is also used, but it's doesn't tend to be used as much anymore in terms of being prognostication. But that actually describes how far in the actual anatomy of the skin. So whether it's just an epidermis and papillary dermis extending fully into the reticular dermis or through into the subcutaneous tissue. Things on the pathology report to include would include the Breslow and the Clark's level, but also the markers for melanoma. So S100 and human melanoma black 45. There are two proteins that would indicate that a tumour might be from melanocyte origin. If you do like an immunohistochemical thing and you actually see if the protein's there, that might be more, obviously if you think it's a melanoma from the skin, that's kind of seems pretty obvious, but maybe if it's like a secondary lesion or metastasis and you want to determine the tumour of primary origin, you can use those markers. Obviously you want clearance margins reported, rate of mitoses per, and how bad the cell, atypical the cells would look would be like a grade rather than stage. And then you want to know about whether there's any lymphatic, vascular, perineural invasion or cancer around those areas because it's roots for metastasis. You can do a sentinel lymph node biopsy to see, like you can use a dye to see where from the area of skin the melanoma is where the lymph drains to, and you can then biopsy that node to see how it's spread. I haven't actually seen that done only in a breast cancer setting, so I don't really know quite how that works in a derm setting. So to treat it, you recommend urgent excisional biopsy. So you biopsy at the same time as you're cutting it out. So you'll often do a 1 to 2 millimeter margin radially, so horizontally in all directions, down to the subcut fat if you suspect a melanoma. And then you kind of do the biopsy at the same time as trying to remove it, but often you will need to get better margins. So you look at the margins, and then you often do a follow-up wide local excision down to the deep fascia with a much greater margin, 2 centimeters, usually, to actually make sure you've removed it all, because obviously people are really worried about melanoma. Based on the margins for melanoma differ depending on what guideline you read or depending on the stage. There's one recommendation there. I read even on UpToDate, most stages, even 2 to 4, they recommend 2 centimeter margins. And maybe you can get away with like a 1 centimeter margin. I don't know about 5, but 1 centimeter margin if it's T1. If you kind of are losing the battle and it's a metastatic melanoma, you can use some of the biologic drugs, even though they're very expensive. Some of them have shown a lot of promise. Vemurafenib is a like BRAF inhibitor, so that's a growth pathway that inhibits of the cancer. And ipilimumab is an interesting drug. So CTLA4 is a protein on T cells that does the opposite to CD28. So that's the co-receptor signal in antigen presenting an activation of a T cell. And CTLA4 actually inhibits B7. So it decreases immune response. And when you inhibit that with ipilimumab, or Yervoy is the brand name, you can actually get more overactive immune system, and that's thought to drive the immune system to kill the cancer. But obviously there's also a risk of autoimmune reactions and things like that, as you would expect. So now we're on to ID, which is what I really want to spend most of the time on. That's what I'm covering. I might not get through a lot of the test stuff at the end, and tables, but it's just there for your reference. So what I'm not covering is this kind of stuff. The only thing probably for 3B that you would have to know that I'm not covering in a bit of detail would be viral hepatitis. I just decided not to do that, but that would be worth knowing. Most of the other stuff there is mainly 4C, I'd say. Okay, so principles of ID. Obviously, you need an adequate history and exam like you would for any specialty. Often you can kind of take a top-to-toe approach when thinking both about the history and exam, about symptoms to try and localize the site of infection. And they call that the focus of infection. Some of the warning signs that are particularly bad is if the patient looks very unwell, if they've got rigors, that indicates a bacteremia. If they've got muscle aches, usually indicates more severe infection, or very high inflammatory markers such as CRP and a very high white cell count. So it says, this is both taken from the MMC ID handbook. I don't know if some of you got that's been circulating, but I found that was really good. And also there's an exam kind of guide there from that handbook as well that kind of goes through a systematic way of trying to identify where an infection could be and what to look for in an exam. Even though you don't really get like an ID exam in Tally, that's kind of one you could use. There's a mnemonic I used for a systems review in ID. The mnemonic was chicky toads. I've modified it slightly to if chick toads, just so I could include immunization and food and drink, because I thought they would, immunocompromised and food and drink were the ones they didn't have, just because I thought they would be quite relevant. So you could see, like, last year we had the hardest station probably on our OSCEs was an ID station, and you've got points for asking a lot of those questions. And also obviously return traveller. Investigations obviously vary depending on the infection, but FBE is often like something you'd always start with. High white cell count could indicate infection, not necessarily. The breakdown of the actual white cells can be really important. So very high eosinophils could indicate parasitic infection. Very high lymphocytes would be used more for an intracellular infection like a virus. And you may see like anemia or thrombocytopenia may be classic of some infections as well. ESR and CRP tend to be used a lot as just general inflammatory markers. They can be signs of like severe infections with like a lot of inflammation basically, but they're obviously not very specific, but people tend to order them quite a lot at Monash, I see. Blood culture is obviously really important. So you can't just take one blood culture. Usually it's at least 2, sometimes 3. And they recommend usually taking them from different sites or at least spaced apart greater than an hour. Ideally, you kind of would give antibiotics before blood cultures, but sometimes you take the blood cultures and then at the same time you get the cannula in and you'll give them antibiotics. And you don't, if they're really unwell, you don't always want to wait for, and you certainly don't wait till the results come back. You always do the aerobic bottle before the anaerobic, because there might be a bit of air in the line through the first bottle. But then when it comes to the second bottle, you've got kind of blood in the line, so it's better for the anaerobic to go second. But most importantly, because if they're a hard bleeder and you don't get much blood, it's most crucial to get the aerobic bottle, because most bugs will be either aerobes or facultative anaerobes, and they will grow in the aerobic bottle, but they may not grow in the anaerobic bottle. Swabs are also really important, and you'll do like and also microculture and sensitivity for testing for like antibiotic susceptibility. Urine really important, as well as starting with a dipstick. Always start with a dipstick and then do a full culture. Chest x-rays for things like pneumonia, LP for meningitis. Lactate can be important in sepsis, so it can be high on sepsis. And imaging might be appropriate, so if you think there was potentially a sinus infection, you might do a CT or MRI, or before LP if there's any suspicion of an space-occupying lesion and you don't want to comb, you don't want the patient to comb when you do an LP. And then there's obviously the tests specific to the pathogens. So there might be there's serology, which usually tests for antibodies against things. So an positive IgM would indicate recent or acute infection, and positive IgG would indicate like long-term or past exposure or immunisation. A GP I went to didn't understand that when I was getting my vaccinations for my med school. So you'd be surprised, like sometimes the simple stuff's like still super important and you can forget it. And PCR is the other thing. So you might actually have a region of the DNA of a virus or a bacteria, and you can target that, and then you can amplify it and see if it's present on PCR. Okay, so some other principles. So the MIND-ME, I'm not sure if everyone's heard of that, but that's for antibiotic prescribing or anti-infective prescribing. So M for microbiology guides therapy. So we want to actually get cultures for most things wherever we can. Indication should be evidence-based. So you go to the antibiotic therapeutics guideline, so you'll know what book that is, hopefully. The narrow spectrum therapy required. So you want to kill the bug that's causing the infection, but not all of the other healthy flora. That's really important because there seems to be like a common mindset in hospital that, especially if people aren't very sure about what antibiotics to use, they'll just go broad spectrum to be safe rather than sorry, which is a really bad approach. Obviously, if they're like really ill and they've got sepsis of unknown origin, yes, you give them broad spectrum antibiotics, but generally you want to use the narrowest spectrum possible. The dose must be individualized to the patient. So if they've got really bad kidneys and you're using a dose that needs to be renally reduced, you need to make sure you actually take that into account, and also the site and type of infection. So you might have like a CNS infection or a bone infection, osteomyelitis, where it's very hard for the antibiotic to penetrate into those tissues, and you might need a higher serum concentration. So you actually give them higher doses. You minimize the duration of therapy as well. Now, because basically you don't want heaps of antibiotic exposure, which can cause resistance in either the pathogens or your healthy flora. That has to be balanced with finishing a course, because you don't want it to be too short either, because you want to be able to kill the actual pathogen rather than leaving a few left over that can become resistant to whatever antibiotic you've used. An oral therapy should be used where possible. So there's often a push in hospital to convert IV antis to oral when they're well or when it's appropriate to do so, because often they're left on IVs too long. There's also a lot of antibiotics that have really good oral bioavailability, so there's no point using IV. So quinolones like ciprofloxacin or norfloxacin or moxifloxacin more used, or metronidazole, azithromycin, doxycycline. You all use most of these orally. The other thing is just making sure, it's really good practice if we can train future doctors to document, just from my work as a pharmacist, document the indication on the chart. And now you need an ID approval number for certain antibiotics, and also review and stop date. With really good documentation, you can actually have much better antimicrobial use. You collect your MCS, as I said, prior, ideally, to the culture. So, because if you give antibiotics first and then take it, you might not be able to grow it. There are exceptions, like meningitis. Obviously, you don't do like an LP or a blood culture. You give them antibiotics as soon as you think they've got meningitis. Consider also when growth likely represents contamination or colonization. So these are important terms to know. So contamination is when you get for example, a normal flora that's contaminated in your sample. Say you don't have good aseptic technique when you're taking a blood culture, and you get like a coagulase negative staph that lives on the skin normally in your blood culture, and it grows, and you think, oh no, but it's not the bug. It's like staph epidermidis, for example, doesn't usually cause disease in adults with a good immune system. So it's likely to get, you have to know which bugs are likely to be contaminants. And that also involves knowing which bacteria kind of live in different places in the body. And colonization just really means that there's bacteria that have colonies there, or they're present, and that doesn't necessarily mean infection. So you might grow a bug, but it might not actually be causing disease. There's often they live with us, a lot of different bugs, so they might be colonized but not causing infection. And there's a sepsis 6 mnemonic, which just kind of outlines 6 things to do in sepsis. So you've got oxygen to think about if the SATs are low, blood cultures, broad spectrum IV antis as soon as possible. There's like a golden hour to give them. IV fluid resus as well, checking their lactate and doing like a fluid balance monitoring with urine output and intake. So this is like a thing from last year's lecture. that I've took, and these are kind of steps in selecting an antibiotic. So first of all, you've got to think, do they actually need an antibiotic? So I've got a lot of infections down here that don't require antibiotics, and there's not evidence that they do much. They make a difference. And when I say antibiotics, sometimes I mean anti-infective, because it also often applies to antivirals and anti-fungal agents and things like that. So some conditions are otitis media, so an infection of the middle ear. You don't usually use antibiotics. If they're like a child, like say less than a year, or they've got really bad ear pain and it persists over like over 48 hours sometimes, but it'll resolve by itself. You shouldn't waste everyone's resources and contribute to antimicrobial resistance by using antibiotics. Pharyngitis is the same. So pharyngitis is, we shouldn't use antibiotics. Mostly, same as sinusitis, they're both usually viral. And even if they are bacterial, usually antibiotics are not indicated. So does anyone know pharyngitis when the main time to use antibiotics? I might just... Huh? Yeah, maybe, but you know why? Like, what specifically? Like, what would you be worried about with pharyngitis? Sorry? No, I don't think so. Anyone know? It's more the specific actual bug and what it can cause, a complication of what it can cause. Yeah, I think someone. Yeah. So strep pyogenes, so group A strep. So that can cause rheumatic fever. But really, they don't know why, but maybe it's genetic reasons. But most say even Caucasian kids and most races don't actually get rheumatic fever from, or rheumatic heart disease from after a strep throat infection. It tends to be Aboriginal, Torres Strait Islander, Maori or Pacific Islander kids under 25. If they have a sore throat, then you can give them penicillin. And you give them phenoxymethylpenicillin. You don't give them amoxicillin, because if it's EBV, you can get a rash. I don't know if that's often been an exam question, but and it's not always easy to tell if the throat infection is bacterial. If they've got no cough, if they've got a high fever and they've got really big cervical lymphadenopathy, and maybe if there's a lot of purulent exudate on the tonsils, it may be more likely to be bacterial. But even like an EBV can produce those things, and that can produce really pussy tonsils, so you can't always tell. So really pharyngitis doesn't really usually warrant antibiotics. Bronchitis is similar. If they don't actually have pneumonia, but they just have bronchitis, again, the evidence doesn't show there's benefit that we should be giving antibiotics. And I'm sure, like as many of you know, GPs prescribe antibiotics so much for all these things, and they shouldn't be. But it's nice to be able to feel like you do something for a patient, which is ultimately why it gets done. Shingles, after the first 72 hours, if you don't get in with that early time, but when the rash first appears, then you kind of, there's not much evidence that they do anything, the antivirals in that case. Conjunctivitis is an interesting one, because certainly if it is like a bacterial conjunctivitis rather than allergic or viral, and they've got like really pussy discharge and stuff, you'd think giving them antibiotics would be the right thing to do. But for the majority of people, it makes very little difference. It gets better by itself and may make it like a day or two of difference. But that's one of on these lists that people still use. If they think it's bacterial conjunctivitis, people always use chloramphenicol, brand name Chlorseq is what people use, but probably doesn't make a difference. Influenza in healthy adults, especially after 48 hours of getting it, again. And the other thing is asymptomatic bacteria. So if you get a urine, for whatever reason you've taken it, but the patient's not got any symptoms, you shouldn't actually treat it. There are exceptions. For example, pregnant women, if we do test their urine throughout antenatal care, and if we do find bugs there, we treat it, because they're at a very high risk of getting cystitis, progressing to pyelonephritis. But for the majority of patients, even if they have catheters in, you don't have to give them antibiotics. Other terms when talking about antibiotics, just to make sure everyone's kind of clear with them, empirical or empiric therapy is when you give antibiotics based on what the infection is, based on what bugs you think are going to be present and what bugs the antibiotic will cover. So for example, in like a skin infection, it's going to be usually staph or strep. So flucloxacillin is a really good choice because it covers both staph and strep, and it doesn't cover anything else. Directed therapy is when you actually know what the pathogen is. So you might have a confirmation of a diagnosis, whether on serology or whether usually on culture, and also you have the sensitivities there, so you know what it's susceptible to, so you can direct the therapy. And prophylactic is use of anti-infectives to prevent infection. So common examples might be a UTI prophylaxis, or if patients are on chemotherapy, they might be on antifungal prophylaxis, and they're often on like Bactrim for PJP prophylaxis. So AMS, I've kind of already talked about it, but giving antibiotics that are too broad spectrum unnecessarily can cause problems both for the person, because it can mean there's more healthy flora and pathogens in them that can actually become resistant, and bacteria can pass genes between each other. More side effects usually, and also it can upset your normal flora. The classic thing is Clostridium difficile that you have to know about. So it's antibiotics they're thought to kill your healthy gut flora, and then the Clostridium, which is often present in quite a few people, that can proliferate because the other healthy organisms aren't growing instead. And there's certain antibiotics that are the high risk for C. diff that you always got to, whenever you get diarrhea, you always ask if they've had antibiotics. Often they might just have antibiotic-induced diarrhea, but it could be C. diff, and that's what you really worry about, especially for broad-spectrum antibiotics and things like clindamycin. And for society, obviously, if we use broad-spectrum antibiotics, we're going to have higher resistance rates, and we'll get bugs that we can't treat. Even like people in hospital will be seriously ill with resistant bugs. And more expensive bugs are usually more reserved antibiotics are also usually more expensive. The other problem is there's kind of not much of an incentive for people to develop new antibiotics, because if they come up with a new antibiotic, it'll be set aside for reserve, and they won't be making much profits in that. And now hospitals have an antimicrobial stewardship team and protocols for antimicrobial prescribing. So I don't know if any of you have seen this, but this is a traffic light system for Monash Health. So you'll have your green anti-infectives at the top, so you can use them whenever. Any doctor can prescribe them whenever, no rules. You've got your yellows, and you can only prescribe them without ID approval for those listed indications. So if it's red or it's an amber that is not under those indications, then you need to get an approval from the infectious diseases doctors, even just a phone consult before you prescribe it, and before nurses can administer it, and before like a pharmacist can actually supply it. We're allowed to give one dose, so that if in a case of a life-threatening infection, you get the first dose, but after that we're not allowed to give more doses until they've got ID approval, which is a really good thing. Because before this, it's horrendous. Like, they did audits in Monash and all hospitals really, but they find almost up to about half of antimicrobial use is not what's recommended. So it's crazy. So now I just want to talk a little bit about some of the resistant bugs you hear about and what particular antibiotics to use for them. So we all hear about MRSA, methicillin-resistant Staph aureus. Methicillin is not really used clinically, but I like to think of it as a flucloxacillin-resistant Staph aureus. Methicillin is similar to Fluclox. It's a penicillin that was designed to resist breakdown from the typical beta-lactamase that Staph aureus produces. Sometimes, however, you can get actually resistance to that as well, and then it becomes an MRSA. So MRSA actually implies resistance to all beta-lactams. So that's penicillins, cephalosporins, and carbapenems like meropenem, everything. Apparently there's one cephalosporin now that were called ceftaroline, but you don't have to know about that. But it's a general rule. MRSA, you can't use beta-lactams, which is, the most commonly used group of antibiotics. So what you use is vancomycin, which I'm sure most of you already know. So vancomycin is used. That's a big thing. MRSA, vancomycin. There are other options. If it's VRSA, you can use usually daptomycin or linezolid. You don't have to know too much about that. Maybe just know that there are those options. The other thing is there's oral treatment for MRSA, rifampicin and fusidic acid. And that's important because we can't keep people on like IV antibiotics for ages, or it's very difficult. They may go with hospital in the home or like a PICC line or something. But long term, we want to be able to give people oral treatment. So rifampicin, the TB drug, and fusidic acid are also active against MRSA. So that's what often a lot of people are on long term. So you may have, say, an ortho-dairy patient with an infected prosthetic hip and with MRSA, and they've grown, and they need on long-term rifampicin and fusidic acid. We had one question, I was at Frankston, but one in a thing that was, you had to use clindamycin, can actually work on a lot of community MRSA, and it's the first choice there. Obviously, you'll ideally actually culture and get the sensitivities to see what it's sensitive to. But if it's not hospital, but it's community MRSA, a lot of them will be susceptible to Clinda, and also some of those sometimes Bactrim or cotrimoxazole. Enterococcus is another important pathogen. So if there's two main types, Enterococcus faecalis and Enterococcus faecium. Faecalis, you use penicillin, and penicillin will work first. If it's resistant to penicillin, or if it's an Enterococcus faecium, you'll use a glycopeptide. So that's vancomycin. The two glycopeptides are vancomycin and teicoplanin. So usually amoxicillin, faecalis, if it's not or is resistant, vancomycin is what you use for enterococci. And that's where the name VRE comes from, because we often use vancomycin for enterococcus infections. But if they become resistant to it, they become the VRE. And then again, you've got limited options, but there's things like daptomycin and linezolid again, and nitrofurantoin's an old antibiotic they use mainly for UTIs, but not much anymore because they've got quite a few side effects. Escapum is another term you might hear. So this is a group of bacteria, most of them are gram-negative rods, I've got them up there, that can actually produce an inducible beta-lactamase. So at first, beta-lactams like a ceftriaxone will work, but then after a few days, the organism will start to produce beta-lactamase that will break them down. Now, obviously, beta-lactamases vary in how much beta-lactams they break down. Some of them just break down like the narrow-spectrum penicillins. Some break down even cephalosporins. Some break down fluclox, and then some even break down meropenem, which are like the NDM1, like the New Delhi metallo beta-lactamases. So just try and not let that too confusing, but it's just the enzyme produced by the bacteria that breaks down the lactam structure. So all beta-lactams have a lactam, which is a lactam is a cyclic amide. So that's the core of the antibiotic, and that's the lactamase enzyme that breaks it down. So in escapum, often you'll use meropenem or an aminoglycoside. So the meropenem will still work. ESBL is extended spectrum beta-lactamase. So that breaks down most beta-lactams. So penicillins and cephalosporins will be off. Usually meropenem still works, thankfully, even though that is a beta-lactam. Potentially you can also use quinolone, so like ciprofloxacin. Pseudomonas is a really important bug to know about. The classic thing that you'll hear is CF in relation to CF, because a lot of CF patients can get colonized and infected with Pseudomonas, and that's a real problem. The biggest thing is there's only one oral antibiotic to use, which is ciprofloxacin. That's it. There's a lot of other IV options, which are all listed there. So usually they'll be put on two. They'll be put on tazocin plus, say, gentamicin or amikacin, or tazocin plus ceftazidime, for example. But when you want to send them home on oral therapy, you've only got ciprofloxacin. Norfloxacin is also usually active against Pseudomonas, but it doesn't reach high enough concentrations for treatment. It only works for Pseudomonas UTIs or Pseudomonas GIT infections. So cut that out. Moxifloxacin, doctors think it works against Pseudomonas. It has partial activity, but it doesn't work well. So not moxifloxacin, that's a common misconception. Pneumocystis jirovecii I talked about before. That's a fungus you'll get. It's not a protozoan, which I think they thought it was initially. It's a fungus, and it's an opportunistic pathogen that grows in immunosuppression. So classically AIDS, or even people on chemotherapy, or even high-dose pred. To treat, use cotrimoxazole, which is trimethoprim sulfamethoxazole, also called brand name Bactrim. And that will also be off. That's why often those people are on lower dose prophylaxis of Bactrim to prevent infection if they're on like immunosuppressants. Stenotrophomonas, you probably don't really have to know, but it's resistant to a lot of bugs, and you use Bactrim again. Atypical bacteria, so usually we talk about this with respect to pneumonia. So atypical bacteria aren't the typical gram-positive, gram-negative. They don't fall into that category. They either don't have a cell wall or they have an unusual modified cell wall. So the antibiotics that we're used to using that target cell wall, like beta-lactams or even vancomycin, they won't work. So you've got to use particular antibiotics. So macrolides, and they target ribosomes, but macrolides and doxycycline. So that would be extremely important to know, both for the exam and both for your careers. So macrolides and doxycycline for atypical cover. Yep. So in pneumonia now, we use clarithromycin most commonly and azithromycin. They're the two. Roxithromycin ID experts, for some reason, have gone off it. It's rule-eyed. A lot of GPs prescribe it. So there's only 4 macrolides. You can remember it with a mnemonic called ECRA, erythromycin, roxithromycin, clarithromycin, and azithromycin. That's also the order of decreasing drug interactions. So erythromycin and clarithromycin have terrible drug interactions, whereas the other 2 don't. But yeah, they're what you'll commonly use. And doxy. Doxy is really the only tetracycline that gets used. Minocycline's used a bit for acne, but it's not a very good drug. Yeah. And the other thing probably to mention that I haven't put on the slide, but anaerobic infections, metronidazole. Metronidazole is really good for anaerobic covers. Here we expect you to know that. So now into some stuff that's a little bit more specific. So UTIs. So a simple cystitis or bladder infection is by far the most common, and it happens all the time in females, both because they've got a shorter urethra and also the anus is closer to the external urethral meatus. Sometimes you can actually get the bacteria ascending up to the kidneys, and when it infects the renal parenchyma, it's called pyelonephritis, which obviously you guys would know about, and it's severe. Most of the time that shouldn't really happen unless there's like vesicoureteric reflux. So you might actually have a renal tract kind of abnormality if you're getting pyelonephritis, which is why you'd always investigate with a renal tract ultrasound. Or and urosepsis is also kind of like mild pyelonephritis, but you get the sepsis as well. E. coli is the main thing. Most UTIs are caused by E. coli, especially in community. So if you're in the community, not in the hospital, and you have UTI, it's pretty much always E. coli. The second bug is Staph saprophyticus down there. In hospital, you get other gram-negative rods like Proteus, Enterobacter, and Klebsiella, and even like Pseudomonas sometimes. UTIs you can break down into uncomplicated, which is most like cystitis, standard female, and complicated. Complicated when it's unusual, like unusual reason. Why did they get a UTI? So it might be that they've got a renal tract abnormality. They might have like an instrument, like a catheter in. When they actually get severe infection, it's considered complicated. If they're pregnant, so it's more for next year, but pregnant women have like I think it was like a 25% chance of pyelonephritis if they get cystitis, which is much higher, much higher, because like the gravid uterus can kind of cause urinary obstruction and cause more reflux. I was going to say, and if there's an unusual bug that doesn't usually cause it, it'll be considered complicated. Also, if there could be actual obstruction from constrictions in the actual, say, ureter, or there might be stones and things that can be considered complicated UTIs. So symptoms, you guys also always know, frequency, urgency, dysuria, nocturia, lower back pain, cloudy or smelly urine, hematuria. So if you actually look at the urine, you'll get white cells and red blood cells, and you also get nitrites. So you can find that all when you do the initial dipstick of the urine. And in pyelonephritis, you might get signs of sepsis, nausea and vomiting, the loin or flank pain that's classic, chills and rigors. You might have like tachycardia, high fever, eventually like low blood pressure, so it's obviously very serious. Elderly patients often don't present classically like younger patients do. So the big thing with elderly patients is like a delirium or an acute confusional state. One of the first things to do is check the urine, because UTI is one of the most common causes of a delirium in an elderly, especially an elderly woman. So that will easily be on an exam as like delirious lady, check the urine, because often UTIs present that way. Okay, so urine MCS is what you do. Obviously, you start with a dipstick and then you send for culture. And you also want to rule out underlying a renal tract abnormality if it's like a complicated case, like I spoke about. And also in like when I'm doing peds, like in kids, I usually always do at least a renal ultrasound, say in less than 6 months or so. So treatment, you always start with non-pharmacological. So protected sex, and make sure you pee after, and generally don't hold urine in your bladder, because it allows bacteria to kind of grow. There's more stasis of urine. You wipe that's for girls, wipe from front to back, so they don't wipe like gram-negative bacilli from the anus towards the vagina. Drinking plenty of water, I guess, to try and flush the bugs out. In terms of antibiotics, so we mainly have to hit E. coli, some other gram-negative bacilli, and sometimes staph. Trimethoprim tends to work really well. There are some bugs, maybe about 10% or so, that are resistant to trimethoprim of UTIs, but still first line. So UTIs, that's cystitis, just cystitis, trimethoprim. That's what we have to know for exam. In practice, I tend to see a lot more cefalexin. I don't really know why, but therapeutic guidelines has trimethoprim first line, cefalexin second line. Cefalexin's a very well tolerated antibiotic, so I can understand why I don't have a problem with it being used. And certainly in pregnancy, trimethoprim can be teratogenic, so you use cefalexin first. Those are the other options. That's just the order of therapeutic guidelines. Doses you don't probably have to know, but it's just there for you. Being a pharmacist, I kind of like, you have to know all the doses, and you will have to know all the doses when you're in medicine, but probably don't worry too much for your exams, but it's there for completeness. Most of them, trimethoprim, girls only get three nights of treatment, and that's it. They give it at night because you're less likely to go to the toilet during the night, so you're more likely to retain the antibiotic in your urine if you take it nocturne rather than mane. Men, usually we give them 7-day treatment, so a bit longer than girls, which is 3 to 5 days, because it's more likely to have a more complicated infection, because they don't usually get infections. If they have a mild pyelonephritis, then you treat, the therapeutic guidelines is exactly the same, but you treat for 10 days, and the cefalexin becomes QID, and the augmentin there, that's augmentin duo, it becomes augmentin duo fort. And if you've got persistently resistant bugs in a UTI, norfloxacin or like quinolones are often used. And you may consider prophylaxis if you're getting frequent UTIs. So for example, if you have more than 3 UTIs in a year or more than 2 in 6 months, it might be appropriate to start someone on some prophylaxis. So that's usually low dose trimethoprim or cefalexin at night. And then pyelonephritis is obviously the severe form. It's affecting the renal parenchyma, and we use 10 to 14 days of treatment. And the best thing to use is ampicillin and gentamicin. That's first line. They did a study, Monash did like a local study of urinary isolates, and they found about like 92% or something of bugs were sensitive to amp and gent in the urine, but ceftriaxone only about 50%. So people don't like using amp and gent, especially they don't like using gent because gentamicin is nephrotoxic and not a toxic, being an aminoglycoside. And also it requires therapeutic drug monitoring, and you know, doctors are cautious about prescribing it, but in pyelonephritis, it is the best option and should be used. And the other thing is you can use gentamicin for the first 72 hours now, according to guidelines, without needing to do the therapeutic drug monitoring to take levels. So it's not too hard to use. Obviously, there are exceptions. So if they've got really bad kidneys, you may not want to use gentamicin, although you can dose adjust and monitor closely. If they've got hearing impairment pre-existing and you don't want any more ototoxicity, like I get that you wouldn't use. Like I think one patient on the ward and they had one ear, they were deaf in one ear and they didn't want to use gent because it's like what happens if the other ear goes. Or a pregnancy, you can't use gentamicin in pregnancy, so you get ceftriaxone. But ceftriaxone is not as good, and it won't cover things like enterococci and just generally local data say it's not as good. It is very easy because it's 1 gram IV daily. It doesn't require a reduction in hepatic or renal disease, and it's just very easy for doctors to be like 1 gram IV daily ceftriaxone for everything, which sometimes works, but sometimes it doesn't work, and sometimes it's not. It's quite broad spectrum, but it's not always recommended. Okay, this is just taken from the AMH. I just wanted to highlight that amoxicillin empirically is not appropriate for UTI because you can see that E. coli is mostly not sensitive to amoxicillin, so you do have to use clavulanate if you're going to use that drug. Same thing for Staph aureus in the skin. So you can't give amoxicillin to someone where you don't know the bug for a skin or a urine infection because Staph aureus and E. coli will often produce a beta-lactamase that will break down the amoxicillin. Yeah, I think that's the main thing I wanted to say from that. So now on to skin infections. So I've done a diagram here that kind of goes through each layer of the skin and what the different infections, the different layers are called. So most skin infections just generally are caused by staph and strep. So Staph aureus and strep pyogenes, which is also called group A strep. Flucloxacillin is a great antibiotic because if you look at its, I don't know if it's here. No, that's gram-negative side. See, it doesn't cover any gram-negatives, and if you looked at the gram-positive side, it would only cover staph and strep and nothing else, which is what you want, you know, in most like cellulitis or impetigo or erysipelas, because you just want to cover the bugs that could be causing the problem. So impetigo is at the top of the skin. That's usually caused either staph or strep. And you get these kind of crusty-looking lesions, erythematous and crusty. They can be golden, and they're called school sores. They're mainly for probably next year in GP, but really common in impetigo. And they can kind of spread everywhere. They may have them on their hands and their face or wherever they've touched. And then you can have sometimes the follicle being infected, which would be a folliculitis, infection or inflammation of the hair follicle. And then if that extends kind of to form an abscess, that can actually form like a boil and stuff. If it goes through into the dermis and just the top of the subcutaneous tissue, then it's called erysipelas. And that's usually marked by a more defined edge than cellulitis. That's almost always group A strep. There's no clear distinction between cellulitis and erysipelas though, because they both kind of can be a continuation. So once it reaches right through the subcut, it's cellulitis. And that again, that can be staph as well as strep. And what cellulitis symptoms are obviously that it's tender, so it's pain on touching, it's hot, and it's red and swollen, and they may have a fever and feel unwell. Cellulitis you see a lot of in the hospitals, you have to know it. And that may be, maybe introduced from, maybe after surgery, it may be introduced after a trauma. Usually it's some kind of local penetration in the skin barrier. It may be like some kind of fungal infection that's broken down the skin barrier so that bacteria can take advantage. And you need to consider basically the severity and the vitals of the patient because these things can progress, and there's always a worry of 2 more deep infections. So there's a worry of necrotizing fasciitis, which is like the flesh-eating bacteria that goes along the fascia, and there's a gas gangrene, and they're both very serious, deeper skin infections. So the signs of them, if they get rapidly, progressively worse, they may have very high, CRP and white cells. They may have pain much out of proportion than what you can see on the surface of the skin. So they may be tender, like for a large area, and you don't see much on the surface of the skin because it's all underneath, and it travels along that fascial plane. And yeah, their vitals, they may deteriorate really, really fast. And there's some characteristic skin changes as well. Neck fash actually tends to be caused by a mixture of different bugs, and gas gangrene caused by Clostridium perfringens is most infections. And the Clostridium perfringens can produce an exotoxins which break down the muscle. So it's also called myonecrosis. And along with that toxin production, which causes the muscle to die, you also get production of gas. And then you can get those gas bubbles, like necrotic gas bubbles. You can see that's gas gangrene there. So this is just a reminder of the different classes of strep. So you've got the alpha hemolytic, which is like strep pneumonia, strep viridans group. Beta hemolytic, which is further subtyped into the Lancefield grouping. So that's where group A, beta hemolytic, comes from, which is like your strep pyogenes. And then you've got your beta hemolytic group B strep, which is most important next year because it can be in the flora of the vagina, and babies can pick it up during delivery and get the most common cause of neonatal sepsis. We get to know the next year. And then gamma hemolytic is like enterococci. They're all kind of gram-positive cocci, and they can kind of be in little chains, so even though enterococci are a bit different. So now onto treatment. So the topical infections like an impetigo or a folliculitis, you can use washes or topical antibiotics. So mupirocin is a commonly used one, which is called brand name Bactroban, or you can use these antiseptic things. Generally though, for skin infections, whether it's cellulitis, erysipelas, folliculitis, whatever it is, you use flucloxacillin. That's what you go for. As I said, why? So it's really narrow spectrum. It targets the staph and strep. It's exactly what we want for an antibiotic. Unfortunately, it's still a lot of people can be allergic to penicillin, so you have to use alternatives like Roxy and clindamycin in some patients. And also it can cause a cholestatic hepatitis. So in long-term Zoocox, you have to monitor the LFTs. The other things you'll see is cephalosporins used. Often they use cefazolin. I think some people think it has a slightly better spectrum or something. I couldn't work it out, but generally they're the two you'll see for cellulitis in hospital, IV Fluclox or IV cefazolin, which is the cephalosporin. Vancomycin, of course, if you might suspect MRSA, that may even be based on a previous swab that was positive for MRSA, so you may need to cover them with vancomycin. The interesting thing I found that I learned last year as well is you've got like a staph septicemia and someone's really unwell, you give them flucloxacillin and vancomycin because flucloxacillin is the best antibiotic because it works the best, better than vancomycin, but there might be MRSA, so you have to give them vanc, but you give them both because flucloxacillin still is a better antibiotic for Staph aureus infection. What else? So boils and carbuncles. Obviously, the ideal thing you need to cut an incision and drainage. So you can't really use antibiotics, so they won't work much. They won't penetrate into the boil or carbuncle when it's really big, pretty gross. Cellulitis, obviously, you want to monitor their vitals, like you would anyway. Supportive therapy, they have to elevate their legs and rest. They may need wound management. Surgery and debridement sometimes, and if they've got tinea, as I said, tinea can kind of cause cellulitis to not heal or make it worse. You want to treat tinea aggressively with, like, say, just like clotrimazole, which is canesten. Neck fash and gas gangrene, as I said, they're potentially fatal, so they need often intensive care involvement even, and plastics are the specialty that deal with that, especially like neck fash. You contact plastics urgently. They often need surgical debridement to take away all that necrotic tissue and prevent further spread, and prompt broad spectrum anti. So they get empirical treatment, meropenem, clindamycin, and vanc, which is like really hardcore broad spectrum, but that's what's recommended for neck fash. And then if you found that it is group A strep neck fash, then you can give benpen because it's like a directing plus clinder. I think there's also antibiotics. Clinder may work on the toxin, I think, or something as well. And sometimes give immunoglobulin for the toxin as well. And clostridial gas gangrene, which is myonecrosis, you use IV benpen because it's just the Clostridium perfringens, and you know that bug, and you treat with benpen. So that's actually quite narrow spectrum. Diabetic wounds are very common in hospital. So they can have a lot of different bugs. They may have anaerobes as well. They may have Pseudomonas. So you've got to cover them with appropriate antibiotics. So they'd be broad spectrum. So oral treatment, often they may sometimes use augmentin duofort, although that won't cover for Pseudomonas. So you may have to use ciprofloxacin. And then IV, all the diabetic patients with diabetic wounds, you pretty much see on IV tazocin, which is piperacillin tazobactam. So broad spectrum penicillin plus beta-lactamase inhibitor. And you've got to consider a possibility of osteomyelitis, so where the infection's gone to the bone. And you need MRI for that, as many of you may know, because X-ray changes often occur only late, so they often need to get MRIs. That was the same thing that I was trying to say before with Staph aureus, with amoxicillin versus needing the clavulanate. So now I want you pneumonia. So pneumonia is separated into CAP, community acquired, if it's in the community, or less than 48 hours in hospital, which means they would have got it outside, or HAP, hospital acquired pneumonia. And you can also characterize it according to clinical severity tools. So CORB is one you can use. So if they've got new confusion, the O2 SATs less than 90, respiratory rate greater than 30, or the blood pressure less than 90, systolic, diastolic less than 60. For example, in Monash Health, if you remember on those, you wouldn't have seen it, but on those traffic light system, if they've got pneumonia and they need a CORB of 2 or more to qualify for the ceftriaxone plus azithromycin for severe, to classify them as severe. CURB 65 is more used to decide whether they need to come into hospital. So that's just very similar. So it's got confusion. Urea, I don't know whether you wouldn't stop to really check their urea before you wait to see how severe they are, but I guess after initial bloods you get that back. Respirate blood pressure and older than 65. So you can see that 0 to 1, you can keep them outside the hospital. 2, hospitalize them. 3 to 5 might need ICU. The other distinction of pneumonia comes from whether we call it a typical pneumonia or an atypical pneumonia. So a typical pneumonia is caused by like typical bacterium, like for example, strep pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, things like that. Atypical is caused by either those atypical bacteria that I talked about before, so chlamydia, legionella, mycoplasma, or a virus. And they tend to be a lot harder to kind of diagnose. They don't present like the classic pneumonia because often they have a dry cough or no cough at all. They often have chills but no rigors. They can have a severe headache. For example, legionella and mycoplasma can give you a really severe headache. Interesting. Arthralgia, myalgia, raised LFTs, similar to what I said, some of those bugs can cause raised LFTs. Have a lower white cell count in CRP, inflammatory markers. Negative gram stain would be because it's a virus or it's a special type of bacteria that don't grow on the normal mediums. And you may hear on auscultation, you may hear like some slight creps, you may hear nothing on clinical exam. And on the chest x-ray, it also may appear like nothing as well, or you may see some patchy consolidation. So it can be less obvious. You might have a normal chest x-ray with atypical pneumonia. In terms of those bacterial causes, I kind of outlined that. The most common is strep pneumoniae by far. Obviously, we've got the vaccine now, which is reducing it, but that only works against some serotypes. Mycoplasma, the atypical, that's actually the second most common form of pneumonia of CAP. Klebsiella and stuff tends to be more hospital. The buzz for that's a red currant jelly sputum, the buzzword, and alcoholic. For some reason, if they're an alcoholic, they've got Klebsiella in the hospital. And then you can just have rust-coloured sputum in like a strep pneumonia, and with a Pseudomonas yellow-green sputum. I don't know if you have to know for your multiple choice. And there, the atypicals I said, mycoplasma pneumonia, chlamydia pneumonia. Chlamydia psittaci is the psittacosis, which is the pneumonia from birds, and Legionella, obviously. Viruses there. Immunocompromised, obviously, will have different kind of bugs. Obviously, fungal or opportunistic pathogens. And what you want to look for on the vitals when you examine a patient with pneumonia is you want to see, if they've got a high rest rate, high temp, high heart rate, or low O2 sats, or low BP. You want to hear to see if you can actually hear localized crepitations, bronchial breathing, dull percussion, not stony dull because of a pleural effusion, but still dull because there's like fluid in the alveoli, decreased air entry, and increased vocal resonance. So they're the features of pneumonia. And those are the common investigations you would do, the standard, including blood cultures, ABGs, to actually, especially if they're really unwell. Sputum MCS is not always very useful. It's very hard to get a good sample, and you may often get a lot of bugs that just kind of live there, and they may not necessarily cause any infection. And especially like you can't get saliva. It has to be like a really good, like chunky sputum sample, which is gross. Respiratory virus PCR is commonly done. So that's with a nasopharyngeal swab. So you stick a swab like up the nose to the back of the nasopharynx swab, and then you do a PCR over the viruses. So you'll commonly see that done in hospitals. So that gives you a whole lot of viruses. And then you can actually do a urinary antigen for Legionella and pneumococcus, which would be helpful. And of course, chest X-ray to like diagnose pneumonia, which you know about. So treatment. We separate into mild, moderate, and severe. So for CAP, we give amoxi and doxy. So that's really important to know. Amoxicillin and doxycycline. If you're like really sure that it's an atypical pneumonia, you can just give doxy, but usually you'll give that. That's what you'll give. Moderate, then you replace the amoxicillin with IV benzyl penicillin, at least for the first few doses before converting to oral amoxicillin, and then you continue on the doxy. And if they're severe, so on that CORB score, if they get 2 or more, then they qualify for ceftriaxone and azithromycin. So that's a severe broad spectrum treatment. And obviously, if there's different bugs, those work on the majority of things, but if there's specific bugs, you may need other agents, say like Staph aureus, you have to worry about like ceftriaxone actually doesn't work that well, Ben-Pen doesn't work, you may have to give other agents, even vancomycin. If they've got allergic to penicillin, you use agents like macrolide for a mild. For a moderate, you often use cefuroxime for oral treatment, but then often they get ceftriaxone if it's mild. Or if they've got like anaphylaxis to penicillin, so you don't use cephalosporins or penicillins because of the cross-reactivity in about probably more like 2 to 3%. Then you'll use moxifloxacin, so severe pneumonia, anaphylaxis to penicillin, moxifloxacin. And then in tropical northern Australia, you get like different bugs, so you actually have to use broader spectrum, unfortunately. Hospital-acquired pneumonia is a little bit different. So the two things is we don't really consider atypical bugs. I guess, I don't know whether they could still get Legionella in the hospital, air conditioning or something, but they don't usually consider cover for atypical. And the other thing is you're much more likely to get resistant bugs in the hospital. So you're going to go broader spectrum. So mild, you'll see augmentin duofort instead of amoxicillin. In the community, GP shouldn't be prescribing augmentin duofort for CAP or like respiratory tract infection, even though they do it all the time. It's not what they should do. But for hospital-acquired pneumonia, yes. most bugs, like most strep and most of these bugs, strep pneumonia, will be sensitive to amoxicillin plain. You don't need to add the clavulanate, but if it's HAP, you do. And then the other thing is we go to ceftriaxone sooner. So even in moderate HAP, you go to ceftriaxone. And sometimes if they're really unwell, they've had like time in ICU or HDU, or they're immunosuppressed, you may go even more broad spectrum with, say, tazocin. They use tazocin. And sometimes in aspiration pneumonia, or they're worried about anaerobes, they may add metronidazole is the other thing to see. So it might be ceftriaxone and metronidazole. Yeah. Sorry? ADF, oh, sorry, augmentin duophort. So that's amoxicillin clavulanate, but it's the high dose of it. Sorry. Hopefully. Just ask questions if you don't understand any of my abbreviations. That's just some pictures. So COPD, exacerbation. Important to note that often they're not infective, and if they're infective, they can be viral. So it doesn't mean all patients with COPD exacerbation should get antibiotics, even though a lot do. We see the ones in hospital, so they're probably quite sick, so they may actually warrant antibiotics. But especially if they've got really increased purulent sputum, you're more likely to want to give them antibiotics. If they've got high inflammatory markers, particularly unwell, as I said, you might want to give them antis. Non-bacterial causes could be a viral exacerbation. It could be, you can think about clots, like even small PE, or heart failure, or environmental pollutants if you've got an exacerbate COPD, but it's not infective. If it is bacterial, the most common pathogens are Haemophilus influenzae, strep pneumonia, and Moraxella catarrhalis. Most of the time, amoxicillin will work against these bugs. Some Haemophilus are resistant, and I think Moraxella is resistant. So they do use augmentin duophort, even though it's not guidelines sometimes. But the therapeutic guidelines stipulates doxy or amoxicillin, which is not much antibiotics as you can think about it, like compared to all the other broad spectrum stuff they could use. So doxycycline or amoxicillin. And then if a chest X-ray actually confirms they've got pneumonia, then you'll treat as, say, for pneumonia. Yeah. So influenza, there's two types, A and B. Influenza A is the one that affects like animals, like, the birds and pigs and us. So you can get different strains from different species coming together, and you can get recombinant strains that change a lot, and that has the potential to create new highly virulent strains. That's called antigenic shift, as opposed to the drift, which is just like single mutations. So they're what can cause the pandemics. Influenza B is often milder than influenza A, and it also only affects humans. Influenza is also subtyped according to the two proteins, hemagglutinin and neuraminidase. And influenza is often like a seasonal thing, so we'll get our vaccinations before winter each year. It's a really common travel illness, so even if they've come back from a really exotic location, always keep influenza right up on your differential list. Just because like we have influenza at home doesn't mean they don't have it everywhere, and it's not super common. It often is the bug in the return traveler when we're looking for all the exotic things. And the vaccine you get each year has 4 strains, so usually quadrivalent. So that's an example of Fluarix brand, but you'll give like so many influenza vaccines next year when you do your GP. You'll get so sick of doing it. When in third year we were chasing everyone around to get three done in the logbook. But yeah, even if they find that they match those 4 strains really well to the influenza that's actually around, they find that it's only 70% effective. So just because someone's had an influenza vaccine doesn't mean they won't get influenza. It's spread by respiratory droplets or fomites. And sometimes you can get a secondary pneumonia, which can make them even sicker. Symptoms obviously like flu-like symptoms, fever, chills, malaise, and they're really the joint pain, body aches, myalgia, headache, are really classic. And you'll diagnose on nasopharyngeal swab, PCR, like I said before, for things. So that'll look at influenza virus, para-influenza viruses, RSV. It can use pertussis, so that's a bacterium. So all sorts of things. So we treat with a neuraminidase inhibitor. So neuraminidase is that enzyme that cleaves off the newly formed virus particle off the cell membrane when it's just been assembled and it's ready to leave and go infect a new cell. So we inhibit that enzyme so it can't leave and can't go on to infect new cells. So there's two. There's oseltamivir and zanamivir. We made zanamivir here called Relenza in Monash, and they made it in my pharmacy campus, and they were super excited about it and proud that they made it. Unfortunately, because it was like an unusual device that they had to inhale and it was hard to use, someone in America made like a Me Too version oseltamivir that was an oral tablet, and obviously that was the one that took off. So that's what you use, Tamiflu, oseltamivir, yeah. But generally, healthy adults with influenza don't need to be treated. We treat those with high risks of getting adverse outcomes. So pregnant women, those who are very elderly, those who have like asthma or COPD, or even you can treat healthcare workers or people in nursing homes where they could spread the influenza around. Be more likely to treat them, like homeless people, Aboriginal, Torres Strait Islander, there's some of the groups. But you really got to treat them within 48 hours, otherwise it's very little benefit. And I think even then it may only reduce the symptoms by about a day. I would argue then that if you get a really severe influenza, wouldn't you want like the drug around? I know in the average person it may reduce it by 1 day that can handle the virus, but yeah, and that's from their therapeutic guidelines and it's like an example of some of the individuals who are at high risk of influenza. So you may treat these or people who come in contact with these people. So TB. So TB is acid-fast bacillus, and Mycobacterium tuberculosis is by far the most common cause of TB. Acid-fast means, so what we do is we do a special stain where you do add carbyl fuchsin, which is an acidic stain, which is red. And then you actually, after adding the stain, you add an acid alcohol, which is meant to wash the stain away. But mycobacteria, they have mycolic acid in their cell wall, and that holds the stain in, so it resists destaining. So it's like acid fast, as in the acid doesn't remove the stain. It's kind of similar to a ground stain in principle. So yeah, they will appear red, and then they will do a counter stain, probably, I don't know whether it's just with like crystal violet, and everything else will stain blue, but the TB will stain red, the TB bacilli. Usually most people, about 90% of people who get TB exposed, they get it through their lungs, don't actually get infection. It just sits there as latent TB and they never know about it. You can only spread it if you've actually got active TB that's respiratory. If it's either latent TB or you've got extrapulmonary TB, then obviously you can't spread it because it's through respiratory droplets. TB can be anywhere. It's really strange. We talk about like a pelvic inflammatory disease and gynae of like TB. You can have like CNS TB. It can be in the bones. TB can actually be anywhere. But the classic thing is obviously pulmonary TB. So if you get primary disease, that's more common in kids or immunocompromised people, and you often get a small peripheral lesion in the middle or lower lobe. Let's do a little diagram there, and then you get hilar lymphadenopathy. But the more common secondary TB, which is reactivated, is when you'll get bilateral apical lung lesions up the top. So that's what you usually see. And then obviously miliary TB, when it's like spread everywhere and it's like the miliary seed or something, like little spots right through the lungs, and then it can disseminate as well. And extrapulmonary TB can be really nasty. On histology, the buzzword obviously is caseous or cheese-like. Granulomas is what you've got to know. So whenever you see granulomas, you think about TB and think about other things like sarcoid or silica and some kind of vasculitis diseases, but TB is always right there. So symptom-wise, loss of weight, fever, productive cough, and night sweats are really important. So if you have that group of symptoms, like you've got to think like lung cancer or TB, and then obviously fatigue, hemoptysis, pleuritic chest pain. So yeah, these are the serious things you've got to think about, for example, on an OSCE. To diagnose, quantiferin gold we usually use instead of the tuberculin skin test. That just confirms that they've had TB. So they may have, most of those people will have latent TB, not active TB, but often they'll get a subsequent chest x-ray and things to see if they've got it. And then to actually, if someone's got clinical symptoms of TB, what we do is we actually need to get a sputum sample, or you can go in with bronchoscopy and do like a washing and then take up those washings. It's called the lavage, bronchial lavage, and then take those and then culture that. And then you do that ZN, the Ziehl-Neelsen stain for the acid-fast bacilli. So you do that and to test to see if you've got acid-fast bacilli. And if you do, you will pretty much confirm the diagnosis of TB. Occasionally there can be other bugs that can be acid-fast, but it's pretty much going to be TB, especially if they're clinically presenting like it. And then what you'll do is you'll start antibiotics. And you'll also culture, but that will take about 6 to 8 weeks to culture. Because it takes 6 to 8 weeks to culture, we'll start them on empirical therapy. So ripe, pneumonic ripe, rifampicin, isoniazid, pyrazinamide, and ethambutol. Pyridoxines with the isoniazid to prevent peripheral neuropathy. So you'll start them on that, and then once at the 2-month mark, like 2 months of all 4 drugs, then the culture should be back. If it's sensitive to everything, you can stop the ethambutol and pyrazinamide, which have some nasty side effects. Ethambutol affects the eyes, can cause like optic neuritis and really bad things. Pyrazinamide can cause the liver. Actually, all of them pretty much can affect the liver, the first 3. But they're the ones that are often stopped. And then you have a further 4 months of rifampicin and isoniazid. And then you finish, and it's 6-month treatment. If they've got like extrapulmonary TB or there's resistance, then it's often longer and more complicated. What else did I want to say? And yeah, drug resistance becoming a lot more of an issue. I can't remember. All right. So meningitis now. So that's inflammation, usually infection of the meninges. Often bacterial, so the big 3 are strep pneumonia and Neisseria meningitidis, which is meningococcal, and Haemophilus influenzae. The 4th is listeria, that's more in like elderly patients, alcoholics, debilitated children, pregnancy. And then viral or aseptic meningitis. It's funny that viral meningitis is called aseptic. I mean, it's still infectious, but it maybe doesn't cause like a sepsis picture. But you can get obviously different viruses. The only one you can treat is HSV though. SLE can also produce an aseptic meningitis. The really big thing about viral pathogens in general, when we develop antibiotics, we can target ribosomes, we can target cell walls. So we can usually use antibacterials to cover a wide range of things. Viruses are different, they're very specific. So you have to target specific proteins. So viral drugs usually only work on one family of viruses. There are exceptions, like some drugs can work on like Hep B and HIV, but usually they're very specific. So we only have antivirals for HSV, which are the guanine analogues like acyclovir. We don't have anything for the rest. So symptom-wise, the big triad that you have to know is fever, headache, and stiff neck. And then photophobia and nausea and vomiting can be other features. They may be very cold, have chills or rigors, cold hands and feet. These are signs of like more sepsis. And the petechial purpuric rash of meningococcal, obviously you guys know that, but that's often quite a late sign. So by the time they've got the rash, they're usually in dire straits. And the 2 signs are Brudzinski and Koenig. So for some people, never remember what they actually were. But Brudzinski, all you do is literally lie the patient flat supine, and then all you do is you passively like lift them up at their neck and you see if they have reflex flexion of their hip and their knees. And that's all you do. Koenig is similar kind of the straight leg raise. You can lie them down, you lift up, say, one leg, flex at the hip, and then you try and extend their knee. And if they get a lot of pain when you do that, that's Koenig's positive. So there's signs of meningitis. Encephalitis is when the infection spreads, not just to the meninges, but also to the actual brain parenchyma. And that's really more severe and really severe. That's often viral. But the things to look out for is an altered mental status. So if they're confused or say their GCS is down, or they've got neurological signs or seizures, you'd be worried about encephalitis, which is more severe. The investigations be like the standard there. LP is obviously the gold standard for diagnosis. CT brain is needed before if you've got focal neurological symptoms or you've got seizures or you've got something that could indicate that you may have a CNS lesion that has that causes raised intracranial pressure, so you don't want to cone when you put the LP needle in. So treatment is obviously supportive and resus, and prompt antibiotics before the LP. So the antibiotic used is ceftriaxone. That's in all people greater than 2 months. Ceftriaxone, that's what you use for meningitis. And you add dexamethasone to reduce like swelling and prevent mainly hearing loss. And you also add benzylpenicillin if they belong to a particular group, such as over 50, alcoholics, pregnancy, immunocompromised, debilitated, because they're at risk of listeria. And cephalosporins don't cover listeria. So obviously ceftriaxone is the cephalosporin. They won't cover listeria, so you need to add benzylpenicillin that will. And vancomycin, you may also need to consider adding if they could have strep or staph. So like even strep pneumonia could be penicillin resistance, although it's usually, very rarely is, but because it's such a serious infection, you've got to consider it. If they have so meningitis may be like a hematogenous spread just from the bloodstream. It may be from like the sinuses, from the inner ear. So you also could consider that. So if it's like from the inner ear or sinuses, you may consider more strep and you may want to cover more with vanc. In encephalitis, you always add benpen to cover for listeria and acyclovir to cover for HSV. When you look at the actual tubes, you might know, you have to know what the LP fluid, the results of the biochemistry and how that differentiates the two. So bacteria have low glucose, whereas virals are normal. I like to think that the bacteria are like eating all the glucose in the CSF, so that's why it's low. You get high white cells in bacterial, and lower in virals. That's just generally like most infections. Even if you did like an FBE, you'd expect mostly the white cells to be higher in a bacterial infection. Neutrophils would be higher in bacterial, whereas lymphocytes would be higher in a viral or intracellular pathogen because you need a lot more, lymphocytes like cytotoxic T cells and helper T cells to fight a viral infection rather than just neutrophils that eat like munch up bacteria. So they're going to be higher in viral. And you have more protein in bacterial as well, much more protein. And I think, again, because bacteria are kind of larger, they have a lot more protein. They're much bigger organisms, so there's more protein. And then the viral, you have slightly increased protein. And bacteria, you can have like a turbid CSF. And that's just the same thing there. Infective endocarditis, so inflammation of the endocardium, particularly the heart valves, which you can get formation of what's called vegetations. So these vegetations contain bacteria, white blood cells, and like sometimes little platelets or fibrin. Although that being said, I said that I have white blood cells, they may consider heart valves as kind of like a privileged site for the immune system. So it can be quite hard for the immune system to attack because you don't really get there. I don't know. I don't really get that actually because it's in the bloodstream, but it's considered quite a privileged site. The most common valve to be infected is the mitral valve. The only thing to know is the tricuspid valve is in IVDU because they're injecting into their veins and then it will go back to the right heart, and the tricuspid valve is the first valve that comes across. Symptoms are fever, chills, rigors, weight loss, night sweats, anorexia, fatigue, and hematuria as well can be a sign. And so a lot of them, it's not very specific, so it can't be quite hard to diagnose. The peripheral stigmata, you just say on exam, no peripheral stigmata of infective endocarditis is like a lot, so you have to say genuine lesions, Osler's nodes, and splinter hemorrhages, and all this stuff that takes forever. Track marks on IVDU, petechiae is another sign, whether that's in the mouth or on the limbs. A regurgitant murmur, that's part of diagnostic criteria as well, because you get valve incompetence. Poor dentition, so like looking at a source, especially a strep viridans, come from the teeth often in those endocarditis. Roth spots in the back of the retina, splenomegaly. So risk factors, I've bolded some of them there. So if they've got a prosthetic valve or they've had like valve surgery and they've got some kind of foreign material instead of their normal heart valve, they're at much higher risk. And that's going to be the critical thing. So if you've got like an OSCE station or even a real life thing, that's what's going to really tip you off more to endocarditis because the symptoms aren't really that specific, but you've got to think about their risk. Obviously, if they had a recent cardiac surgery, so there's potential for contamination, IVDU, congenital heart disease, they're more susceptible for getting bacteria there. Other things there you can read. The complications, obviously, valve insufficiency is a big thing, so you get valve regurgitation. Heart failure, the septic, you can get little septic emboli, so rather than made up of like fibrin or platelets, they're mainly made up of bacteria. And they can travel and cause like similarly infarction and things, like a blood clot would, from initially the cardiac source, which I've seen actually in hospital a few times. Glomerulonephritis as well, and you can even get like an abscess forming from maybe started as like a septic embolus. So what you would do in investigations, you'd do all the general stuff, you would do multiple blood cultures, you would repeat them at least 3 times. You would do an echocardiogram, which is how you diagnose it, along with maybe CT. An X-ray of the jaw could be used to check for, like, say, a tooth abscess or infection or something, which could be the source. A colonoscopy if they have strep bovis, so this particular pathogen is associated with colorectal cancer. It might be an exam question for like, I don't know, but it's very specific. So you diagnose with a modified Duke criteria, which I have on the next slide. So in terms of the echo, usually perform a transthoracic echo first, but obviously it's a lot easier. You just do it through the chest wall. And then if that like kind of rules out endocarditis, but there's still a high clinical suspicion, you probably will proceed to a TOE. Or it may actually confirm it and you'll be happy, or you may want more detail on the scan, so you may actually still proceed to a TOE. If they have a prosthetic valve first, you're meant to go with a TOE as first. And the three things you look for is a vegetation, a perivalvular abscess, or new onset of regurgitation, or if they've got a prosthesis, it's like coming away or dehiscing. And then often they need 6 weeks of antis. And the antibiotic stuff's there. You probably really don't have to know that. I saw like strep, so they'd be on benpen and low-dose gent. The gent would be to like kind of disrupt protein synthesis so that the cells would be much more susceptible to the penicillin getting through, and that's unusual. So they use very low-dose gentamicin in endocarditis often with the other antibiotics, which is different from when we use gentamicin, say, in a urinary tract infection. And then staph, obviously, flu clox, MSSA, VANC, MRSA be the same. And Pterococcus, you'd want to use penicillin if you can, maybe sometimes gent and VANC. And then cardiac surgery may be necessary for some patients to get rid of vegetations, or if they've, you know, got their valve repair after the valve is actually like ruptured, or if they've had prosthetic material and that's become infected and kind of got ruined and they need a replacement. That's the Duke criteria. So the major things is you need 2 positive blood cultures with an organism that usually causes it. You need evidence on echocardiography, and then you need a new valvular regurgitation. So you hear the murmur when you're listening. And then the minor criteria is like a risk factor for a TEMP, vascular phenomenon. So that includes stuff like the Janeway lesions and stuff, or immunological phenomena and micro evidence, but not quite meeting the main criteria. And that I got from Toronto Notes, but it kind of outlines the major pathogens for the different groups of endocarditis, which I found quite useful. Okay, so we are getting there, probably another 15 minutes or so. Sorry, thanks for being patient. So now I want to talk a little bit about travel medicine. So there's a lot of different travel bugs, and this was what our OSCE was last year. So the top of the list always kind of has to be malaria whenever you get like an exam question or OSCE station. But also think about some of those other things. We had dengue last year, influenza. And basically what you'll do is you will look at where they're going, exactly where they're going, and you can use resources like the CDC website or Smart Traveller, and you can look at what organisms are there, and you can consider what vaccines they need to have, if there's vaccines for them, how to protect themselves. So could be like mosquito bite prevention, protecting themselves from mosquito bites, like using nets and insects with high DEET and long clothing, and not going out at night or like dusk for, you know, so you don't get like arboviruses like malaria or dengue. And they may be involved malaria prophylaxis depending on where they're going. So that might also be different depending on whether they're staying in like in Thailand, maybe if they're in like Bangkok in the middle of the like city, they don't need malaria prophylaxis versus if they're going to like some rural village in the jungle. And you also think about like food and drink, so they're not eating street food or drinking bad water, avoiding animal contact so they can get like zoonoses from, not swimming in certain lakes and things because you can get parasites. And even like you have to consider like sexual activity because people can be reckless and overseas. It's just like they always say, don't forget that because it's easy to forget. And yeah, so in terms of when the traveller returns with a Prexer of unknown origin, you have to kind of get the exact itinerary. So you want to know where they've been, including stopovers and the dates of when they were there. And that can be important for kind of the incubation periods of different illnesses. So how long after they get the illness. So dengue is usually like about four days or so after. So it's got quite a short incubation period. Malaria is usually like 2 weeks. I mean, it can vary, but you can give you an idea. Sometimes, say dengue, if they come back and they develop it 2 weeks after they're in a dengue area, it won't be dengue because it's too long an incubation period. So I was going to say, you want to know the activities they did, sick contacts. So the two things to always ask in infectious disease history is travel and sick contacts, and I guess immunisation as well. And they're the bolder diagnoses that I would consider you probably have to know, when they would probably give you, probably not melloidosis. That's probably more in reality, because in Southeast Asia, like Thailand, Vietnam, there's a lot of melloidosis, and it's actually a really common cause. That's a bacterial Burkholderia, cepaceae, an organism. You probably know that for practice, but not for OSCE. Measles, you would get like the maculopapular rash and the 3 Cs, cough, coryza, and conjunctivitis. And the big thing for that is the Koplik spots on the oral mucosa, which are like little white rice grains. And then hepatitis, if you get like a jaundice station, your return traveller, plus or minus either sexual use or IVDU, it'll be like hepatitis. We had dengue last year, which was probably the hardest OSCE station. It was a bit of a curveball, but you get a rash, which often can look like a measles-like rash initially. You can get really severe pain behind your eyes. It's a buzzword, retroorbital pain. You can get myalgia, arthralgia, and bone pain. So it's called break bone fever. Obviously, you get like a fever, but usually not lasting for that long. You can also get thrombocytopenia in dengue. So you might have bleeding manifestations, whether like blood noses, or you might have part of the rash actually maybe like petechial from low platelets. That's probably the main thing. And that's just like a list. Most of this stuff comes from Emma Bishop when I was in Frankston last year, and it was brilliant, absolutely brilliant, but probably above your level, and 3B. And that's an example of a list that I tried to copy from her for the for like investigations you could do in a return traveller to try and run through everything. So you want to kind of think about urine, think about the feces, think about the throat. You think about all the different serologies to do, imaging, blood cultures, etc., etc. So malaria, so most commonly is Plasmodium falciparum or falciparum, and that's also the worst type. There's other types there. There's a complex life cycle, which I won't go through, but that was a good YouTube link that I like to watch. So if they come back from malaria or subtropical regions, always consider it kind of up the top of your, because they just like to do it on exams. They've done it before a few times. Often they can get a flu like prodrome. Obviously the remitting fever, so they get a fever and then they're afebrile again for a few days and they get a fever. That's like the classic thing for malaria, and when the fever comes down they get the sweats and the chills. That's variable depending on the type of malaria and based on the patient, but it's still what is pathognomonic for it. They often get abdomen pain, diarrhea, headache, myalgia, all those things. Jaundice, they get hemolysis because initially the malaria forms in the liver, like it forms schistons or something in the hepatocytes. That's where it infects first. And then the second stage is it releases into the bloodstream and it infects red blood cells and causes hemolysis. So you can, in severe malaria, you can get like quite bad jaundice. You can get like dark urine from hemoglobinuria, which is called like black water fever. And also the big thing is you can get hepatosplenomegaly. So the thing to diagnose them, you do all those things, but you want thick and thin films to check. So the thick films is like you just want to find malaria somewhere, and then the thin films is you want to actually be able to more characterize the type and look at it more closely and count. And you do that with a gem sustain. The thing to look for in falciparum malaria is banana-shaped gametocytes. Is often on like the exam, which is one of the stages of the sexual stage of the life cycle. So prophylaxis, we use doxy most commonly. So use that 2 days before you go, while you're there, and 4 weeks after. It was 2 to 4 weeks, but she said, the lecturer we had said 4 weeks is best. And the alternatives, those are Malarone and Mefloquine are alternatives, but usually people just use doxy. You can still get malaria when you're on doxy, but it's much less likely, and if you get it, it's probably going to be less severe. I actually saw one case of malaria we saw in Frankston last year, and I went to interview her, and she had taken doxy, but I think that might be some of the reason why she didn't get it so bad. Treatment's interesting because treatment is with this artemether lumefantrine. I never heard it, like you'd almost never heard of it, but it's these tablets called Riomet, and you have a box of 24 tablets and you take 4 doses at this period, 0, 8 hours, 24 hours, 36 hours, 48 hours, and 60. And that's what you use. Second line Malarone, which is the atovaquone proguanil. And then in severe, the thing to use is IV artesunate. I'm not going to go through like the drug classes and actions because it's a bit too much information. That's just some pictures. That's the remit, the tablets they use for the treatment. That's the life cycle. They're the banana-shaped gametophytes up the top. PUO, paroxysmal unknown origin, is when you have a fever greater than 38.3 for greater than 3 weeks and you've done at least some thorough investigations. It does differ, but that's the general definition. It's not to be confused with like fever with unknown focus. People often use PUO when they've got a fever and we don't know where it's coming from. They should use like fever of unknown origin or fever of unknown focus, not paroxysmal unknown origin, because it's got a specific definition. So the 4 categories are those that go remaining undiagnosed: infection, autoimmune or connective tissue and like rheum conditions, or malignancy. That's an example of a differential list. Again, you need to consider normal systems review ID questions, an adequate history to try and an exam to try and localize the pathology. And then there's some of the investigations, which probably is not worth me going into, but they're an investigation list that you can do. That's from Tally, a list of PUO. I really like learning the herpetic. I think that's really useful to know that. So human herpes virus 1, which is also herpes simplex 1, is cold sore virus. Can also cause other things, like you can see there. HSV2, the genital herpes 1. HHV3 is chickenpox, varicella zoster, and also shingles when it's reactivated. HHV4 is Epstein-Barr virus, or mono or glandular fever, and that's associated with glandular fever-like illnesses with a lymphadenopathy and sore throat, and you feel really unwell for usually a while. It's also associated with, say, chronic fatigue, lymphoma, some kinds of cancers and things. CMV is human herpes virus number 5, and that's a congenital infection, so it can cause quite severe disease in a baby, like affecting their eyes, their ears. It can cause anemia and things like that, and it's also an opportunistic pathogen. HHV7 is roseola. Again, that's like a rash and a febrile illness in kids, and there's a link, I think, with pityriasis erosea. And HHV is Kaposi's sarcoma. Usually you see that in AIDS, but yeah, I really like that list. So all of these viruses, we can use guanine analogues like acyclovir, valacyclovir, because they're all in the same family. So just group them together because they're in the same family. Viruses like the hepatitis viruses are completely different. Even though they're ABC, whatever, they're not the same viruses, but these at least come from the same herpes viridae family. And that's just pictures for you. And the last thing I've got is HIV. So obviously HIV infects the CD4 plus cells, which are usually helper T. You can have like macrophages with CD4 that can infect, but it's mainly helper T cells, which kind of cripples your immune system, your specific immunity. Seroconversion is usually after about 2 to 6 weeks, but it also depends on the type of test you use. So this is a retrovirus, so it starts at, that's wrong, it starts at RNA and goes back to DNA via reverse transcriptase. So that slide is an error. And obviously the transmission is unprotected sex, high risk is MSM, IVDU, healthcare workers, and it can be from mother to baby. So, and mothers are meant to receive antiretrovirals during their pregnancy, not breastfeed. HIV can produce acute illness in about 40 to 90%. It varies. It's like EBV, so they often have a sore throat, fever, headache, really big lymph nodes. They may have diarrhea, a bit of mucosal ulcers, muscle pains. They just feel really lousy. And then there's often a long period where the immune system kind of keeps HIV in check until it kind of loses the battle eventually. And the problem with HIV virus kind of keeps mutating. So there's constantly new T-cell lines that have to be made against it. And each time that T-cell response is kind of weaker and weaker with less helper T-cells. So eventually you kind of get AIDS, where it's either usually defined as a CD4 count less than 200, or you have an AIDS-defining opportunistic illness. So that's a list. That's like, I know that's like a lot of information, but that's just a list that I got of all the opportunistic pathogens for HIV, for AIDS, sorry. And there's also other things. It's not just the infection. Even if people are on antivirals, they're at a high risk of lymphoma. just because of all the, immune reactions and constant turnover of cells. They're at high risk of lymphoma. And also they're at increased risk of inflammation and cardiovascular risk. So often these people, might have a lower threshold to use a statin or aspirin or something. We diagnose with HIV serology, but what does that actually mean? So classically, it was just antibody testing, and that was usually seen to be reactive within 6 weeks. And then you would confirm with the Western blot, which was you would run the proteins on a gel and then transfer them to a membrane and then try and label it with antibodies. Yeah.
We're still doing serology, or do we use PCR instead?
So we use, I think we use ELISA and serology. So basically now what we usually do is antibodies plus P24 antigen. So this antigen is meant to be a more earlier marker. So obviously your body takes time to make antibodies, but the antigen can be present earlier. So most places in Australia, I was trying to read, but they do P24 as well. So hopefully this can pick up a lot more people in that acute period where they've just picked up HIV, say in the last month or so, and like a lot of the time they can be negative, and they might actually not truly be negative because they've only recently picked it up.
With the Western blot, is it actually gold standard, or is it just
this is what I read. I actually changed these recently, so the slides are, but that was what I was taught like last year, but I was doing some reading, and now I think they don't even need the Western blot, because if they have the antibodies and the P24 antigen, they can just do that. Yeah, so that should pick up most things. Interestingly, I'll come back and forth. Where is it? There. So you can still see with the P24 antigen, you still have maybe a seroconversion period of 15 to 20 days, so time after you get the virus until when it's positive. So you can still miss people in that early period. So there's some rapid tests as well that just use ELISAs, and they may be less specific. You can actually get positives in the people who don't have HIV, which you can imagine would cause all sorts of drama. And also they may often not pick up the people with early infection. The other things to do is obviously notification and contact tracing. So it's really important to try and figure out where they've gotten it from and any people are at risk, which is probably very sensitive and very hard, because it's very difficult for time patients and not to be told like they have to go tell everyone. So there's obviously services that support them and tell. They can anonymously message people. You would also always screen for other STIs. So when you do STIs, when you suspect an STI, it's really common to do everything. You just do everything group, because often they can be present together. The pregnancy status obviously is really important to consider, and just don't forget that for your exams, just generally even vomiting, abdo pain, putting them on a drug or a test that could harm a baby. Just consider it. If a female of childbearing age is pregnant, probably will be more likely to be tested in 4C, but we actually did have a station where they had a PE or suspected DVT, it must have been PE, suspected PE, and they were possibly pregnant, so they didn't want to do like a CTPA. They wanted to do what's it called? The other one, BQ scan instead. Yeah. Okay, so the other thing, CD4 count is like this, more quantifying what you want to find out what the CD4 count is. That also influences what prophylactic antibiotics and things they need to get. Their viral load, their genotype. If it's like a follow-up visit, you want to know what past drugs have had and any resistance. Hepatitis, if that's concomitant, you really need to identify that, because some drugs can hit hepatitis as well, but you can get resistance because if you're going to treat it, you need at least multiple drugs active against both HIV and Hep. Usually it's Hep B that they talk about, but you want to identify both. Obviously, you want to look at other opportunistic pathogens like TB, if you've got latent TB and they could be reactivated. One thing I didn't mention in the TB I wanted to say is, even if you're in Australia, we still see heaps of TB. And it's also because we've got a lot of migrant populations, but also people who are Australians, but they've travelled or, they were born in other countries. They may have got TB kind of been exposed when they were little, and then it's just sat there for ages, and now they're adults and they suddenly get TB. So TB is a lot more common. There's a whole big TB clinic that we have when I work as a pharmacist. I spend mornings doing TB drugs, so don't think that it's not present in Australia. And what else to say? Oh, fasting lipids and things, because a lot of they're a higher cardiovascular risk, and also some of the drugs, usually more the older drugs, can cause adverse cardiovascular effects. and kidney effects and electrolytes, because again, they can cause renal toxicity and some of the drugs. So there's no prevention, no current vaccine. You can use PEP within ideally 72 hours, but up to 5 days of exposure. So you've got to either get antivirals after a high risk exposure. Say you've had unprotected sex at high risk. There's also PrEP, which is pre-exposure prophylaxis with Truvada, which is this emtricitabine tenofovir, which is reverse transcriptase inhibitors. That's not really available yet, but it's probably going to come in for like high risk, maybe sex workers, MSM, that they can take like a regular. So they've increased. They're still recommended to use condoms, but they can prevent their chance much more. And the antivirals now are very effective. You can't cure HIV, but you can certainly control the viral load to an undetectable level. But they need lifelong treatment, and they really need good compliance to the drugs, because if they get resistance, they're in trouble. So that's the therapeutic guidelines that I've got. So usually it's two nucleoside or nucleotide reverse transcriptase inhibitors. So they are like an analogues of the DNA. So they actually inhibit it at the active site, whereas the non-nucleoside and reverse transcriptase inhibitors are allosteric inhibitors. So they'll actually target somewhere else on the enzyme. So that's what the difference is. But you'll use that, and often they do that. So emtricitabine, tenofovir, and efavirenz is ARRI. So that's commonly used. I've just put all the brand names next to all this therapeutic guidelines so you can actually see what they've used. Especially last holidays I worked at Monash, I saw a lot of these, and like I tried to start learning them, because you give them out to people and there's so many and they're quite complicated. That was what I said. Okay, so we're done. So let's quickly, I've got some review questions. I know you guys probably want to go, so we don't have to do them. And this is just at the end, you've got some antibiotic tables, just a summary, like what infection and what to give. And then I also just included what ceftriaxone won't cover at the very end, because I think that's a really commonly used antibiotic and people need to know like what it doesn't cover. So I think if you have the PowerPoint, you should have all the answers at the bottom in the notes section. So do you want to finish? Because I know I've gone like over time and stuff, so you guys probably want to go. What does everyone think? Here. Oh yeah, good. Okay, thank you. Thanks very much, guys.
And a massive shout out to James for that amazing presentation. For all of you at home, that was our last revision lecture for the year. So I wish you best of luck and Godspeed.